Good evening and welcome. I'm Katira Kapoor, and I have the privilege of being the Senior Director of Health Promotion, Wellness, and the Spark Your Health Talk series here at the 92nd Street Y. Thank you so much again for being with us. This evening, Spark Your Health is joined by leading obesity medicine specialist and author of the Ozempic Revolution, which I have right here. So much to unpack, Dr. Alexandra Sowa, for an in-depth discussion on the current landscape of GLP-1 medications. Our format this evening will be a moderated discussion followed by 15 minutes of Q&A. So please feel free to be submitting your questions throughout the duration of the program, as we will be collecting them from the chat. We hope you will join us for upcoming Spark Your Health events, such as Demystifying Perimenopause and Menopause with Dr. Michelle Tollefson coming up this Wednesday. At this time, I would also like to thank our Spark Your Health Talk series sponsor, Mount Sinai Health System, for their generous support. I am now pleased to introduce our guest this evening. Dr. Alexandra Sowa, thank you so much for being with us. Dr. Sowa is a trailblazer in obesity medicine, known for her unique blend of scientific rigor and thoughtful patient advocacy. Her dual certification in internal medicine and obesity medicine, along with her role as a clinical instructor at NYU School of Medicine, sets her apart as an expert deeply committed to advancing treatment paradigms. Through So Well Health, she extends her reach beyond the clinic, offering innovative telehealth services and resources that reflect her philosophy of care, holistic, evidence-based, and deeply respectful of the emotional dimensions of health. Thank you so much for being with us.
Thank you. What a nice intro. I appreciate it.
Really excited to dive in. There's just so much to talk about, and I showed the book, but of course, in preparation of this conversation, I went through this, and there's a wealth of information, and certainly helped me understand things better because there's just so much information coming out about GLP-1s. I mean, at record speed, if you do just a quick Google search, you'll see articles, probably 30 articles just today.
Yeah, totally. I bet there are more.
yeah, exactly. So it's nice to have, like you said, an evidence-based, book that we can look through and really talk about, when is this right for someone, and just unpack those questions. So let's jump in.
Okay.
So I wanted to start the conversation from an exploratory perspective for those that are curious and wondering if a drug like Ozempic is right for them. The use of GLP-1s has really brought to light the fact that obesity is overwhelmingly genetic. And I'd love if you could get into the science behind why this is the case and how this ties into going on a diet versus taking a GLP-1.
Okay. Oh, so much to unpack here. And for clarity for anyone listening, I call this book the Ozempic Revolution, and we're using the word Ozempic to kind of cover the class of drugs. But really, as you said, it's GLP-1 medications. I chose the Ozempic Revolution because colloquially, that's what we've come to understand. The brand name drug Ozempic is for management of type 2 diabetes. Wegovy, Zepbound are for management of obesity or overweight. So just to kind of get that out of the way, because people are like, oh, you're saying you're using a drug for weight loss that's for diabetes. No, we're talking about the class of drugs. So who is this right for? So we use this when we are looking at excess weight as chronic disease, and we have specific criteria for that. And we look at it as chronic disease because we know actually that it downstream, there are so many diseases that are tied to excess weight. And it is something that is like high blood pressure or osteoarthritis. It's chronic, it's relapsing, it's progressive, and it's often impossible to treat on your own. And so we are so thankful that we now have many tools in our toolkit to help people with the chronic disease of obesity and overweight. It is genetic. I write in the book that it's a little bit more complex than just genetics. Really what's come to play is a concept of epigenetics, wherein we have genes, but the environment around us defines what these genes do in our lifetime. And so for a long time, and in many sections of health and in the world and society and in our own brains, we still blame ourselves. We really do. We say that this is all willpower and you're clearly doing something wrong. You're not eating right. You're not moving enough. But when you take a step back, many people who suffer from the chronic disease of excess weight and obesity, they're doing all the right things. Something about the world has changed and predisposed them and kind of made their genes so that it's almost premeditated that they will have excess weight. Something very clear happened around 1980 in this country, where we went from a disease state of like 10% of the population could be classified as obesity, as having obesity. And then something tipped over, and every year the graph of how many people suffered from this just went up and up and up. And only it's not until this year, and we likely can say that the downtrend that we saw in a little bit in some populations was likely because of these diseases, but otherwise we've just seen a steady increase year over year over year. Our genes don't change in a population, but what changes is the world we're living in and our body's response to the changes around us. So people will often say on a surface level, if they hear about what I do and the book that I wrote, they'll say, oh, you're just saying you can fix everything with a drug and that's it, and we don't want to get to the root cause. And that's not what I say at all. I'll say, okay, we have a tool where we can help fix this population, and let us use this bandwidth that we have and the world around us to start changing what happened in 1980. And we can argue this for days. That's a different panel, but probably it had to do with corn subsidies and the environment around us and the world, how quickly it started changing with technology and how we were living, how we were vacationing, how we were working, or really how we were shopping and buying food. And then very quickly, those changes in one generation started to be passed down through utero. So a mom who carried a little bit more excess weight passes that kind of epigenetic change on to their children. You eat differently in the home, you shop differently, you live in a world where there aren't sidewalks, or you're not biking, you're walking to school, you're driving, all of these things. So we need to start to peel that back and change the epigenetic changes and the environmental changes that have happened. But yes, long-winded answer, obesity is primarily genetic, and our body wants to live at the highest weight that it's either seen or that it could potentially get to. And that is a protective biologic response to being animals in the world. Unfortunately, our animalistic instincts haven't realized that we live in a world of abundance of calories and energy-dense foods, and it can be very tough to maintain normal, healthy weight.
Yeah, and I think you mentioned in the book that there's a tendency for even on a GLP-1 that, people may come into it thinking, okay, I'm going to be a model and I'm going to be a size zero. And it's like you mentioned in the book, you're really probably going to go to where your body wants you to be, kind of where genetically that kind of set point is. Is that right?
Yes, and that's even in the most ideal of situations. I often will say that I have to refer patients to therapy, not at the start of the journey, but actually toward the end, because it's at the end, they might be disappointed with where they got to, because in their head, they fantasize about getting to a certain number on the scale or finally being able to want to go to the gym. And then they're like, but my body still is my body. And, I am who I still am, and this medication isn't going to change that. I'm not going to grow 6 inches and, be a size zero if I go on this medication. The other thing that I think people have an unrealistic expectations about where GLP-1 medications can get you is that if you're starting in a significantly excess weight range, on the population average whole, even the most effective medication we have right now will lead to about 20 to 24% total body weight loss. And that might not even look like thin on your body. And so people will have in their head, they'll see on social media this quick transformation and this overnight success and these very, very dramatic transformations. But that really shouldn't be the goal here. And it's not what most people are going to achieve.
Got it. So in the book, you mentioned that there are superpowers that GLP-1s bring to the table. Can you break down for us what is happening to the body on a GLP-1 when it comes to blood sugar, our hunger volume, and appetite control?
Yes. So the superpowers have to do with how and where these medications act on the body. And interestingly, we make GLP-1. We have native GLP-1 hormone. That's how we discovered this hormone analog. And but our hormone is not as strong and it's not as long lasting and it doesn't have such a dramatic effect. But we have receptors to this hormone all over our body. But the biggest ways that we see them are in our brain. This first superpower is it quiets our brain from constantly thinking about food. And you'll hear on social media this concept of food noise reduction. That's not a scientific term. That is truly a term born out of patients who are like, oh my gosh, I'm not constantly thinking about food. I'm not constantly thinking about my next meal. I can eat, I can receive that food, I can be done with that food and move on with my day. And it's very dramatic. And not all people will experience that. And not all people will go on the medicine because they're constantly thinking about food. They might actually eat very little and they might need additional support. So the second superpower is in how this medication works on blood sugar. So it makes our body very, very quick to respond to small spikes in blood sugar, release insulin. Insulin grabs blood sugar and levels it out very normally. In that process is we avoid storing food as fat. We are more effective at burning it, what we consume quickly, and energy expenditure just goes kind of back to normal. Also, that blood sugar regulation is where we see a whole host of other benefits that we are now declaring with these medications, where we reduce inflammation, we reduce coronary vascular disease, we reduce things potentially like dementia and Alzheimer's and all of these other diseases that come from the inflammation of blood sugar. So that is its very dramatic effect. And then it also works on the level of the stomach and the GI tract, and it moves food through your system more slowly. And so it balances out hormones because your body will say, I'm full longer. And it just gives a signal to the brain that you don't need to eat again and you're satiated and you're complete. And it connects to the brain very, very effectively between the gut.
Got it. So, well, I might be jumping here, but you, in your So Well method, you talk about skipping meals. And, as you're talking about the food noise, I'm wondering if that's something that you see with patients. Is there an importance to kind of maintaining some regularity around meals?
Yes. So in the book, we go through all of these kind of how does the medicine work and how the myths and the science of overweight, obesity, and weight gain. But then really at the core, and why I wrote the book, was that I was seeing so many people on these drugs thinking it was a magic wand, but really people need core foundational habits to really do well on this medication, to thrive, and then to continue to keep the weight off. And one of my core foundations is nutrition. And in talking about nutrition, people think, okay, well, this drug is just going to help me eat less. Well, it will, but that should not be our goal because we know what significantly calorie reduced diets do over time. They lower our basal metabolic rate and they make it so that our body constantly is working to regain that weight. And so at the beginning, when you start this drug, it can be so effective that you're like, I don't need to eat. And your old school part of your brain, I think you're younger than I am, but the way that I grew up, we were eating SnackWells and fat-free everything and skipping meals, right? And that part of your brain kicks in. You're like, oh, this is exciting. I don't look how many hours it's been since I ate last. I love this drug. That won't work for us in the long term, though. And so it's really a core tenet that people eat regular meals. Now, they're not going to be very big. But I want people to be conscious of the fact that it's time to eat and we should be getting in something. That might just be a protein shake. It might just be bone broth because you're not that hungry, but it's really important to give our body nourishment and not focus so much on just calorie reduction. Instead, what can we get in during this time? That's going to help us maintain our muscle, which we will talk about because as we lose weight, we lose muscle. And so you need to make sure that we're actively rebuilding that. It will help us hold on to our basal metabolic rate. And also, our body's pretty smart. That idea of like, saying that we're animals. I always tell my patients, really, like, we're built to run in a forest. And if you stop feeding yourself, your body's going to do everything it can to hold on to whatever fat stores it has left because it thinks it's in a famine state. And so same thing will happen on these drugs. I find that patients will hit plateaus and they will not thrive at a certain point if they just stop eating, and they won't feel very well either. So it's really important to focus on that. A lot of patients will have come to me having done intermittent fasting because there are health benefits to intermittent fasting. And it has been very trendy, over the past 10 years or so. But at a certain point, it will stop or will start to work against them. So we actually have to like reverse that. And I'll say, okay, it's time for a little breakfast. Like, we just have to train your body again to work on a food schedule.
Yep. Now, do you find so one of the reasons that exercise solely is not a great way to lose weight is that you tend to increase your caloric consumption after exercise. Do we see that pattern holding true at all when someone's on a GLP-1? Does that hunger kind of kick in a little bit after exercise?
It can, but it's not a reason to not exercise. What
Okay.
I would say is that I give exercise is important, but the right sort of exercise is even more important. So a lot of the exercise that we've kind of been trained to love, like really sweat it out, really work hard, work long and hard, it can work against us a little bit for the reasons that you said. It can fatigue you. And again, we're animals running through a forest. So if you're running, sweating, your body's like, oh, I got a break. You better fuel up, right? And so your hunger can increase. You can eat more. You can reward yourself a little bit more. And your body will say, well, something must be going on because you're just running. You're going. On a GLP-1, if you love to do a certain workout, I'll say continue it. Just be careful that you might need to stop a little bit earlier. You listen to your body's responses. You need to hydrate specifically with electrolytes. I'm a big fan of electrolytes before the workout, after, because to get the water into the right parts of your body, you need a solute or a salt to aid you. And that becomes even more heightened on a GLP-1. I also really want people to focus on building muscle.
Mm-hmm.
And there's a really big push for this, especially in the female midlife menopause community now. We're starting to realize, gosh, our grandmas did it wrong. Just sitting around and getting weaker is not it. And then the generation behind us just, doing aerobics wasn't it either. You have to lift heavy weights. And really in the GLP-1 world too, it's very, very, very important.
Yeah, and I think you mentioned in the book, you said something about the speed that you're losing matters. Can you talk about that a little bit? Because if you're losing weight very quickly, you're losing muscle mass that quickly as well.
Yes. So whenever you lose weight, you are losing muscle plus fat. We don't have a way to just lose fat. There are actually some drugs in development that will potentially be muscle sparing weight loss drugs, but we don't have them yet. So you have to be careful about how you're losing weight. And the headlines are often these drugs or lead to muscle loss. They don't. They don't more than traditional calorie restriction diets. And in fact, the ratio of holding on to muscle is probably better. So we have to do things that support holding on to your muscle. One, we need to focus on protein, and that is very, very important. And we need to focus on weightlifting. And we don't just want to lose weight for the sake of losing weight. We want to actually shift our body composition. And I'm very excited that the world is starting to understand that testing body fat is not evil, and it really, really shouldn't shy away from it. We should understand it and use that as a metric, as a tool to really understand and guide us to health.
Yes. And speaking of protein, do you recommend adding in protein powders also?
I do. So I love whole real food.
Mm-hmm.
Like, I will say that I want people to eat whole real food. The recipe section of my book is called Food to Make When You Don't Feel Like Eating. Because often you don't feel like eating big meals, or the meals that you traditionally ate, or some foods you might lose your appetite for. leaning into foods that feel like comfort foods and are easier to get in are very important. And so protein shakes can be a big part of that. I believe in this so much that I created a line of products for GLP-1 users called Sowa, and you can find us in retail rolling out across the country this year. Protein, electrolytes, and fiber. I want you to potentially add this to a smoothie with yogurt, so we can really bulk up your protein. But if on the day you're just like, I really don't feel like eating anything, I would much prefer you to take a protein shake made with water and very little else just to get in some protein. And I don't think we need to look at it as a bad thing. What I don't want, though, is to harken back to the days of like, eat 2 shakes and a sensible meal. I don't want that because one, it's triggering, 2, it's not good nutrition. On a random day, if you can only get in 2 protein shakes, I'd rather you do that. But I don't want that to be a substitute for life in a weight loss plan.
Right. It's the healthy granola bar in the bag kind of
Yeah,
concept. Yes.
exactly.
I want to go back to brain health for a minute because you talked about the food noise and kind of how that's quieted a bit. Do you find with patients or like in the health field as a whole, does it quiet other things in one's life? I'd imagine that might be a question that people have is it going to quiet my mind for the better? Or that could possibly be a negative thing for some people who are thinking, oh, I'm a foodie and I love going out to restaurants. And talk to us a little bit about how you're seeing those that impact.
So I write about a patient in the book who very successful in life. She told me that I gave her 4 hours of her day back after starting this medication, a low dose of this medication. And I said, what do you mean? And she's like, well, I just was constantly thinking about what I was supposed to eat next. She wasn't obsessive, but she was like, I always was worried about what to eat for health, what to eat to potentially lose 5 pounds, what to eat to maintain my weight. And it's just gone away. And so for her, that what felt like an obsession, even truly, it was not a diagnosis. It was just, it occupied a lot of her brain space and then it just quieted. And she's like, I have time for hobbies. I'm more present with my kids. I'm more available at work. Thank you. And it's continued for years now at this point. And that was the first time anyone put it like that to me. So in the majority of cases, patients' mental health improves. Not only are they losing weight, something that has potentially been a struggle for a very long period of time, or they've internalized that they are a failure because they have not been able to do it on their own. It reverses disease, it prevents disease, it gives some people so much solace in knowing, I'm not just on a path like my mom, my dad, my sister of this disease to progress. I've kind of nipped it in the bud and have taken control, and I feel very in control. Does it affect other parts of the brain? Yes, positively. So we know that this drug is being studied for opioid and alcohol addiction because the same parts of the brain that can be obsessive and constantly desire food also desire these other things that in excess can be harmful. So good things. Now, I do find that for certain people and in certain circumstances, it can take away subtly a little bit of pleasure. Mm-hmm. So especially if your whole world is wrapped up in the pleasure of food and drink, it can be a shock at the beginning if you do something that kind of just puts a stop to that. Like you just don't want it anymore, and you might not recognize yourself. You might have to reestablish relationships. The contract of how you and your husband generally like to spend your Saturday nights, or how you and your girlfriends go out for your margaritas. And, it can be disrupted and it can feel shocking. And for some, it can feel very sad. Now, most people, again, are not even having that response. But if that is kind of the way that your world is built, it can be difficult. Mm-hmm. If it's also your comfort at any given time. So if you're an emotional eater and you know that like your comfort at the end of the day is to have ice cream or a glass of wine, or it's to sit on the couch and constantly snack on something, and you take that away, you could feel potentially just empty, maybe not sad, but like, what do I do? So we talk in the book about I find it's really important for people to identify even before they start this journey is to start tracking what they eat, how they feel, some of the patterns so that they can recognize that they have, gosh, every Saturday I do this one thing that's really tied to food, or every afternoon I'm doing this to get a break from work. I'm eating this. And so that we can come in and find other things to take the place. So hobbies. Or you can get ahead of the fact that instead of going out for a bar trivia night, you're like, can we go bowling instead? Can we do something that's not as tied to just drinks? And so it's reroutable, but it is something really important to work on. It's the third foundation. So we have habits, we have food, and then the mental foundations. And that's a big part of the mental foundations of long-term success. I have had patients who write to me, or social media, people on social media will write to me, or even patients are like, listen, I really want to stop the med because in the next 3 weeks I have a birthday party, a wedding, and I'm going on vacation and I can't enjoy it. And I'm like, hold on. Let's talk about what is actually enjoyable about these events. Let's really think about it. And are we going to stop something that's been working so well so that you can go backwards into habits that weren't actually helping you live the life you wanted? And really, when people can unpack that, they're like, okay. They're like, you're right. What I really want on vacation is relaxation. What I really want at that wedding is spend time with family. And on my birthday, I want to be excited that I'm having a better year than I did last year. Okay, I'll take a breath. But if you get too wrapped up and you can't understand the mental underpinnings to what you're doing and how to rewire, you'll just be like, oh, okay, I'm just going to take a break, because being on this medication equates not being able to do food and drink in excess.
Hmm. And that actually brings me to a question about microdosing. Is that something that you're seeing out there? Is that something that's been advisable in any way? I'd imagine whenever there's any kind of drug out there that's working, there's, variations that people play with.
So this is like everyone's favorite topic these days. My fear about the general conversation around this medication is that it's been driven by social media. And the way I see it, been driven by influencers who, up until about 18 months ago, vilified these medications. And now they have a new way of using these medications. And they're going to tell you that their protocol is better than what the FDA and clinical trials have set as standard. I also think, though, that there's a misconception of what microdosing means. So traditionally, in the dosing schedule of these medications, you kind of go up every month, especially with semaglutide. It's kind of like every month is on a titration schedule up. But not everybody needs that. And so I'm a big fan of being individualized in the approach of how do you take this medication. And if you're having success at the lowest starting dose and you continue it and you're doing great, well, okay, let's call that microdosing, because it's technically an eighth of the dose that some people need to achieve weight loss. But if you're doing great, that's great. I get worried about kind of making protocols that haven't been studied. And we do know that certain doses work for the desired outcome. That's how we set the standard dosing. And so sometimes I think that people are talking about using this for just general benefits that are anecdotal and actually don't have outcomes that we want. And these drugs are expensive. There is a potential risk, which I'm sure we'll talk about, risks to them. And we have to make sure risk is smaller, benefit outweighs risk, and that we're getting what we want. And I'm a believer in science and evidence. So I like to follow what science says, but it should be personalized. So with a caveat to that.
Yeah, no, thank you for that. Well, because you brought up the risk factor, I'll jump into the qualifying factors. What can someone I'm guessing some people with us tonight might be curious about GLP-1s. So what can you tell them about the qualifying factors and what kind of tips the scales, so to speak? I know it's different for everyone.
Yes. So from a weight loss perspective, the FDA has pretty clear guidelines about what they say that these medications are indicated for in terms of weight loss. So a BMI is what they use, body mass index, which is super inexact science, but it is what it is. So a BMI greater than 30, which puts someone in the obesity category, or a BMI of 27 or greater with one issue, health-related issue related to your weight. Now, I will say, actually, if you dig and look at the the instructions in all of the GLP-1 medications that in the last few months, BMI criteria have actually gone away. And we are seeing expanded use case scenarios for them. I think we need to be very careful about what that means, but I do think looking at metabolic health rather than just a number on the scale is really the most important. This is actually what's being missed in most of the prescriptions that I see out in the world being written. So thankfully, these medications are very effective, and thankfully, they are very safe generally. So people are like, well, we don't need to do much of a workup. But the field of obesity medicine is looking at the whole of a person, and we want to know why. Why did weight come on? Sure, we could just say that it's genetics or epigenetics, but often there's something else going on. There's another medication you're on that potentially you don't need. There might be a medical condition like sleep apnea. There could be hormonal changes at play. There are larger things. Insulin resistance is a big one that I see go undiagnosed, and people have no idea that they're on the cusp of type 2 diabetes, but it's there and no one's even checking for it, or the fact that we have fat in our liver. So I'm a big fan of doing like a complete metabolic workup. I give that toolkit to everybody in the book. Like, this is what I do. Here is my plan. I want you to get these labs checked. And ever since I wrote the book, I get so many social media messages from people being like, I'm so disappointed. Nobody ever looked at my metabolic health. So I don't even know where I started. They were just using the BMI criteria. So I'm not even sure if I should stay on this, need to stay on it. Did it improve anything there? And I don't want to have to go off of it to find that my lab markers got bad again, you know?
Yeah.
So metabolic health, I think, is actually the biggest lens at which we should look through whether you should be on this medication. And I don't always think we need to be necessarily exactly by the book, by a number on the scale, but more of your story. So someone might not meet the criteria by BMI, but they've gained 40 pounds on a medication that they cannot get off, and now they have insulin resistance for the first time in their life, and the stepwise approach of other medications and tools that we have hasn't worked. Well, then you're probably a good candidate for this medication. The difficult thing right now is convincing your insurance company of some of those subtle changes, and instead they still hold on to the BMI criteria if you are one of the lucky ones whose commercial insurance does cover these medications for weight loss.
Right. And how are doctors navigating age as a factor? Because and please correct me if I'm wrong, but it seems to me that the intention is, because the GLP-1 is not effective when one is not taking it, it's pretty much like you're going to be on this for a long time. Is that right? So I'm curious how that impacts like younger folks who, I've seen stories of like teens.
Yeah. Well, so you are right all across the board. This medication, because it's replacing a hormone that has kind of become unresponsive in the traditional sense, and then we fix it with this hormone, you do need to keep taking this hormone to get the same benefits. And that's a big misconception that people have a really hard time understanding. It is approved for use in younger populations with some stricter criteria. I'd say that I am an adults doctor, so I don't work with the pediatric and adolescent population. But unfortunately, when weight comes on earlier and families and individuals are doing everything within their grasp to help, the child, adolescent to achieve a healthy weight, but we're starting to see things like fat in the liver or insulin resistance or type 2 diabetes. These medications are a very good choice because having that disease onset so early will have significantly negative outcomes down the road. But yes, you do need to factor that. It's like once we start taking it, you will be on it potentially for your whole life. But I'd ask people to, it seems, I think, scarier because it's an injection and it's an expensive injection. And that is the biggest barrier, I think, right now. And I hope in the next few years, this drug dramatically decreases in price. But for adolescents, if you had a hypothyroid condition and you needed to take Synthroid, which is a synthetic hormone, really no one bats an eye. They're like, sure, go on it. Great. You might have to be on it for life. You probably will be on it for life, but it's helping to fix something. And so the kind of the same thing here. But no one is saying go on this drug. It's a magic wand. Do nothing else in your life to change your environment or behaviors or food patterns. But we'll use this as a tool to help you achieve the healthiest life you can possibly live.
Yes. And I mean, you led me right into the next question, which is you mentioned in the book, this is not something to go on and to think it's a quick fix or that it's effortless. So, can you tell us a little bit about why it's not effortless and what other pieces a patient would be expected to take on?
Yeah, so I ask my patients to do a lot, actually. And really, it just comes down to this good foundational habits that you need to really embrace for this to be about health and not just quick fix weight loss. That weight loss, in my opinion, comes back. Really, if you're just doing this like super quick and you're not changing any of the other parts of your life, you're going to be disappointed and you're not going to achieve as much loss as you potentially could. And it's not going to be for health. And that is, I always say, skinny is not motivating. Like just weight loss, those patients like give up. So like, I don't want to figure out the side effects. I don't want to figure out the strength training. I would rather just eat my nachos. Like, because really that's more enjoyable than actually the process of being skinny. So the habits are really important for just keeping you on track. And so we have these specific habit foundations. Some of them look familiar. I'm like fully the first to say that, like stepping on a scale every day. You've heard that before. But through the frame of being on GLP-1 medication, some of these habit foundations are very doable and they help you just stay accountable and honest and stay connected to the process. I have people log. Again, I'm a big believer in I am not a calorie counter and I never have been, and I never ask my patients to do that. But like, what are you eating? Are you eating the right things? Are you making sure to get your protein in? Are you getting your fiber in? Are you eating when you're sad, even through the medication? Like, what do we need to do there? Are you having a reaction to a specific food? I think that the journaling part is very important, and the data gathering part is a big important part of this. And I also want people to really embrace the food and nutritional changes. Again, I don't ever even talk about a calorie in the book. We talk about macronutrients, and I need people to really understand what 30 grams of protein per meal looks like. And we need to be creative in how we're preparing that protein. How are we making it fit into our world? Because honestly, the takeout that was your go-to before, you're not going to feel great. So the side effects that come with these medications are often a byproduct of how we eat and what we eat. And so we really need to eat not just for weight loss and health, but so that you feel well. And in my opinion, they're tied because up to 66% of users will stop these medications by 1 year. And a big portion of those are stopping because of side effects, because in my opinion, no one's teaching them how to eat. And no one's saying, hey, you got to actually pull back on carbs because carbohydrates will give your body, it's so good at grabbing up that blood sugar, but you're going to have a negative GI response and might lead to diarrhea. So you got to focus on your protein first. And if you eat too much fiber, like big leafy green salads, you might actually have a terrible stomach ache because your body can't handle it yet. So you need to know your food, how you respond to it. And then finally, in the foundations, it's really just about consistency and then kind of getting to the gym and the strength training. And I talk about red flags because the things that work for you in the first year, you need to make sure you keep doing them because sometimes they'll start to fall away. And I'll tell my patients, hey, if you recognize that you haven't weighed yourself in a week, well, that's just a big red flag and you have to figure out why. If you stopped preparing your food and you're ordering out all the time, that's a big red flag. Just what happened? Like, don't blame yourself. Like, what happened? Because we need to get in there and pivot and go back to some of the basics. And so the foundational tools help us keep going. And so that year 1 weight loss turns into year 5 weight loss and then year 20 and 25.
Yes. You mentioned the scale, and I'm sure a few of us cringed just a
I
tiny bit.
know.
But you do have like a really wonderful, quick explanation of why that's important. Can you just let our audience know why that is?
I know it's true. It's the thing that people literally like when they join my practice, they're like, "Oh, I knew you were like everybody else." And I'm like, "Just listen to me and try it." And they're like, "Okay, this has like changed my life."
Yeah,
So
you had interesting reasoning.
yes, so the scale really is just a tool. And I talk throughout the book about the concept of emotional neutrality. We have been so conditioned to be so emotional and tie our worth to our body and to the number on the scale that it is literally palpable. It makes people just want to like their stomachs just turn over when I say step on a scale. I encourage people to take the power back on that relationship, and not to be afraid of it, but to actually just make it emotionally neutral. This is just something that shows us, hey, is this journey working? Is this medication working? Am I eating enough? Did I lose more weight? I don't even actually think you asked me previously about how much weight you should lose per week, but there is like a number. I don't want people losing more than 1% of their total body weight per week. So if you're losing more than that, I need to know that on the scale. I don't want to just go by the way your pants feel, which is often so like how people get to me. They're like, oh, I was just kind of going by sizes, and then I went up 3 sizes. I want you to try to just say, okay, this is just a thing I do, just like brushing my teeth, right? If I forget to brush my teeth one day and I didn't pack my toothbrush, I'm not going to tell myself I'm a terrible person, and I'm not going to give up entirely on the journey of brushing my teeth. I'm just going to go figure out how to get another toothbrush, right? And the same concept with stepping on the scale. I'm a woman. I've had 4 kids in the past 10 years. I totally understand it. I understand that it can be very hard, but the more I find that people embrace just a routine around it, they're like, okay, it's just my day, time of the day, or the day of the week that I'm going to step on the scale. I'm going to log it. I'm going to walk away. The crazy thing about stepping on the scale is generally when I see patients in my practice after they get to a place of they're losing and they're in maintenance every 3 to 4 months, I'll check in with someone and they'll 9 times out of 10, they'll say, I'm doing terribly. And we have a way of sharing weights with each other. And I'll be like, are we looking at the same numbers? And they're like, no, I forgot. What was I doing 4 months ago? I'm like, well, you've either maintained or you have lost 3 more pounds. And they're like, really? I'm like, yeah. People have like the funniest, foggiest memory when it comes to their own journey. So the scale can just say, this is what it is. It's like a blood pressure cuff. It's just a measurement. That's it and nothing more.
I like it. Yeah, it's just data collection.
Data collection. That's it.
All right. Well, we'll get ready to shift over to, we have a lot of audience questions coming in, but
Good.
you did mention side effects and
Mhm.
something we were talking about right before our conversation started, which is not new information, but is this possible side effect of blindness? And I do feel like these, not a high percentage
No.
likelihood, but I'm just curious if you think, over time as we're, because this is still new, somewhat new territory, do you think we're going to see more side effects coming about as we do longer term studies? Do
Well, so these meds have been around since 2005, and they have
Mhm.
been studied at the level of hundreds of thousands now. What's happening? So the risk of blindness is called NION, and it's in a very specific patient population, very, very, very rare. And we have definitely not established causation. There is potentially a correlation in some subsets of people who are on this medication with other conditions who then are on this medication and experiencing that. What I think we're seeing now is just that more and more people are on these medications, and we will study. So this we have reporting processes in medicine. When you start to see different things, you will report and we will study it. I would not have keep any patient from this unless potentially they had a history of NION before, and if they had a history of like vascular events and I needed to work with their ophthalmologist, okay. But for the general population, no. And so we have to remember that correlation does not necessarily equal causation. But I do think we'll continue to see small subsets and studies, and I think we'll get a little bit more personalized in which medications, because there's so many more drugs GLP-1 medications on the pipeline about this one is good with this genetic panel. This one is good with this history. This one is good. And I think we'll get a little bit more nuanced. And yeah, never say never. We may see some association or correlation, but on a population whole right now, really studied deeply with very safe outcomes.
Okay. And we actually did have a question in the chat about that very topic. So I'm glad that we covered
Good.
that one. All right. So I mean, I have about 20 more questions for you, but we're going to jump in because we have a lively audience and I want to make sure we get to them. So okay, so and we'll just remind everyone that we'll answer very generally speaking. We of course
Yes.
cannot answer specific questions that you would ask your own doctor. So are these drugs okay for someone that needs to lose 20 pounds and has tried to lose weight through diet and exercise?
So I think it comes back to that question of just taking a personalized approach and looking at metabolic health. So 20 pounds on a specific frame can actually firmly put somebody into the overweight category, the BMI greater than 27. I think we have to be careful if you are starting off very thin with a very low BMI and your body puts on 20 pounds. Should we be doing everything possible to get back down to a super thin BMI? Probably not. But I also, like 20 pounds is significant. Did that come on over 10 years? Was it associated with hormonal changes? I think that deserves a conversation with a specialist. I'd say in nuanced cases where it's not cut and dry, going to an obesity medicine specialist like me is probably the way to go, because a general doctor is like, well, that doesn't fall within the boxes. And that's probably the right answer for them. But like dig a little bit deeper and see what's going on and see if we could find something else that might be able to reverse to help you lose 20 pounds, potentially without the aid of the medications.
Got it. Do you recommend one GLP-1 drug over another?
Yes. So it really has to do with how much weight you have to lose / access to medication. So there is a clear winner in terms of percentages of weight loss right now. Tirzepatide, which is Zepbound or Mounjaro for type 2 diabetes, has a much larger weight loss percentage by about 10% more than what we see with semaglutide, Wegovy. So if there is much more weight to lose, I will kind of jump ahead to a dual agonist, GLP-1 plus a GIP hormone that's in tirzepatide. Also, that is preferred if semaglutide leads to significant GI upset. There's less GI distress with the dual agonist. But I will say, for a long time, I only had single agonist drugs, had people lose a lot of weight, and it just depends on what you want. And then sometimes I'll switch people over to the more effective drug and they're like, I don't like the way this one talks to my brain. I don't like what it's doing. I want to go back to the other one. So it's not like you have to jump right ahead to the dual agonist. Many people will do great on semaglutide.
Got it. Are there any special concerns, special dietary considerations for a patient with non-alcoholic fatty liver disease taking GLP-1 medication?
So I would say actually it's the same thing that I would say to the general patient, but even more so. So fat accumulation in the liver is generally made worse by excess energy from carbohydrates. So a low carbohydrate diet will both aid in melting the fat from the liver. That's like kind of, that's not very sciencey, but it's the truth. Like really, it tends to just kind of melt away and get the fat comes out of the liver cells as we lose weight. And also it will allow you to feel well. So I write in the book, I'm not advocating for a very low carbohydrate diet for the majority of patients on this medication, but I do use that as a therapeutic tool in some scenarios. And actually non-alcoholic fatty liver disease is one of them, where it will actually help with even more weight loss and will kind of help heal the subunits of the liver and get the fat out of there.
Got it. Interesting. How do GLP-1s work for a person with thyroid disease? Is it safe to take with with a thyroid medication?
Yes. So definitely safe to take with a thyroid medication. The only people that we are very careful, and I used to say avoid, but now we're very careful about using GLP-1 medications in, is someone with a history of medullary thyroid cancer. So that's the one type of thyroid cancer that we have to be careful of. It's a very rare type of thyroid cancer. And so if you have hypothyroidism or if you have another type of history of a thyroid cancer, you can still be on these medications and it works great. Anyone who's had hypothyroidism or thyroid disease knows that once the thyroid is altered and is not as responsive as it was kind of built to be, it can be very hard to lose weight. And so a lot of patients with hypothyroidism are seeing success on these medications, and it can be really life-changing.
It. We have a question coming in from someone who's actually been on Ozempic,
Mhm.
and they're actually, as we said at the beginning, everyone's a little different. They're not getting that sense of not being hungry or being less hungry, not losing. So, do you see patients interacting with these medications differently?
Yes. Okay. Should definitely read my book. You are so diagnostic for exactly what I say. So I'm reading the question. Okay. Um, if you experience the sense of fullness at the beginning, at about 5 months on a specific dose, generally the feelings that you felt at the beginning start to fade between 5 and 12 months. 5 months is like the start point where people are like, I don't think it's working for me anymore. And that's normal and natural and expected, and all the studies show it. And I reference it in the book where it's like the food noise will come back some, the hunger will come back, but the benefit of the drug and the weight loss will still continue. Now, if that's not you and that's not what you meant, I just don't feel it at all and it's not working, it's not the right dose. So I do see this kind of both in the concept of microdosing and then people who are like, unfortunately, who are trying to really make the pen work for a lot longer, they'll just stay at the lowest dose for a long period of time. If you're not losing, then, and you're really not feeling it at all, it's time to up titrate. So Ozempic actually comes in much smaller dose pens because it was really built for blood sugar control. The weight loss versions of that same drug under a different name, Wegovy, go up higher. We need more of it for weight loss. And if that class of drugs just isn't doing it for you, then switching over to the dual agonist medication will work. But also, if it's working and you're losing weight, you're just not feeling it like everyone else on the internet is saying they're feeling it, that's fine too. Like, again, we are individual and hunger is not the enemy.
Hmm. Wow. Yeah. Okay, interesting. In patients with chronic renal conditions that are advised to not consume high protein diets,
Mhm.
what alternatives are there to prevent muscle loss if you are on one of these medications?
I would say working with a renal dietitian, you'd probably be able to get more protein in than you think. We're not going to give you bodybuilder levels of protein, but you probably don't need that anyway. So you should be able to protect your muscles. Even if you have a cap on protein, you should be able to get sufficient protein in at every meal.
Yes.
And it doesn't have to come through meat alone. I mean, I'm a fan of beans and other sources, non-meat sources of protein.
Do you have any recommendations for the most common side effect, which I believe was nausea?
I do. Check out Sowa electrolytes. They're behind me next to the book, but really it's B6. So B6 is therapeutic doses will help with nausea. But so if you're doing all the right things, B6 is really it. And electrolytes will often help. So I think it depends on when you experience the nausea. If the nausea is because you haven't eaten anything all day, you need to have something in your stomach. That's stomach acid, and reflux can really trigger a nausea sensation. B6 will help, electrolytes will help, a little bit of salt will help. If you're experiencing the nausea after meals, I really want you to pay attention to the size of your meals. This can be so triggering for a patient to hear because they're like, I'm eating nothing. I promise you, I'm not eating much. And I'm not saying you're eating too much. I want you to eat a smaller portion though, because sometimes it's just even too much for your stomach and your brain is like, I do not feel well. I also want you to really watch and keep a log of what you're eating and how you're feeling. Often I will find that it's carbohydrates. It's simple carbohydrates that trigger the GI upset, including nausea. And you'll find kind of that strike that balance. But electrolytes, B6, hydration, and a little bit of food, that generally does the trick. And if that really doesn't work, then ask your doctor for a prescription for Zofran because that's an anti-nausea. Important point about that drug though, because people want it. Like they're like, oh, can I just have it? It causes constipation pretty quickly. So then you oscillate with this other problem that you can have. So you have to be very careful. I want people to treat it more holistically before jumping to a med.
Yes, so many things to consider. All right, I think we have time for one or two more questions. This is a good one. Someone's asking, what happens when we or if we do go off the medication? Because there's a lot of other aspects that we didn't talk about that GLP-1s can support. And so just
Yeah.
curious how that may impact someone that decides to go off of the drug.
So studies are very clear. In the vast majority of users, 95% of people, weight will come back. And unfortunately, all of the cardiometabolic benefits that we see with the weight loss, or even if you maintain some of the weight loss, you will still generally see the cholesterol go back up to where it was, the hemoglobin A1C, blood sugar, and we don't really have the studies to show this yet, but potentially all the other benefits. So all of the cardiac benefits, the kidney benefits that we see, the brain protection benefits, they won't be there either because all of the cardiometabolic benefits fade very quickly too. So this medication is very revolutionary in how it's helping us to prevent disease once excess weight and cardiometabolic dysfunction is set in.
Uh, okay, lastly, what alternatives do you think are better for body composition and excess body fat screening other than the BMI? Because we
Yeah.
said that was not so great, like a waist to height ratio.
So I actually provide example scales in the book. So there we have tested at-home body composition scales. I reference them in the book. That can be great. There is some margin of error with the at-home testing. You can go get a DEXA scan that really looks at how much body fat and where you're carrying it. Unfortunately, insurance never covers those, or a nice fancy body composition scale that you can find sometimes at gyms. And old-fashioned, these are so talk about triggering. You're going to hate me because I said the scale and now this, but old-fashioned calipers can actually tell
Mhm.
you about how much body fat you have. It's just that who really wants to pinch themselves? I never wanted to do that to patients, but that is actually something and probably the cheapest. And then we can also look at because it doesn't always have to be about body composition so much, but where we're carrying our weight. Specifically for women, we can also look at the hip to waist ratio too. And there is a downloadable printable tape that I've created over on my website that's in the resources section for this book. I link it out because that actually, if you don't have one of those paper tapes at home, you can also tell something about that too. And so kind of back to that question of, if I only have 20 pounds to lose, well, if we know that you're carrying visceral fat, belly fat, and your waist circumference is larger than we hope, then maybe you are a good candidate. What I will also say in terms of BMI, something we didn't touch on at all, and I think is really important in this conversation, is that weight and metabolic health determinants are different among different populations of people. And I think we talk about this in broad strokes for the Caucasian population, but we have very different cutoffs in Asian, Southeast Asian, Mexican populations. It's different. So you should be treated again as an individual, knowing if we have lower cutoffs. And I talk a little bit about this in the book too.
Yes, absolutely. Last 30-second thing is just, I know that they just came out recently approving, I believe, Ozempic for kidney disease. And just wondering if you have any insights on the future, on the next few years. Do we see these drugs impacting any other diseases?
Yes. So my prediction is that we will start to see approval for brain health in specific populations. And we will see continued benefits. So we have approval for sleep apnea now, treatment, kidney disease protection, heart disease prevention, stroke, cardiovascular. We are going to continue to see added benefit, and hopefully what that does is also allow for expanded access. So right now there's a proposed bill sitting in Congress. We have a lot going on in our government these days, but the bill is sitting there, the proposed rule is sitting there that would allow for coverage in Medicare and Medicaid of these drugs for the first time. there has been a long-standing, very outdated rule that said that Medicare and Medicaid would not cover any drugs whose indication was weight loss. And so now it's actually been pretty intelligent for the drug companies to say, look, we're going to invest a lot of money into showing you this is not just about weight loss. This is about all these other added benefits. And that is forcing the government's hand, hopefully, to bring down the cost of these drugs and to really provide coverage for a much larger population. So I do see a lot of exciting things happening in the next 5 years. And I think it's exciting, but I also think we need to be paying attention to what do we need to do to reverse and prevent what got us here in the first place? Because my goal is not for my grandkids, for everyone to be on these meds. It's that we are able to get back control of our epigenetic and environmental world, and we're able to kind of go back to some basics here.
Absolutely. Well, Dr. Sowa, thank you so much for being with us this evening. Thank you for this. I mean, I really think that we just really scraped the surface of what is in the book and all of the things that one can do leading up to possibly going on to a GLP-1, making sure it's the right decision for them, and then how to maintain a positive, healthy lifestyle afterwards as well. So thank you so much for being with us. You've got a lot of positive remarks coming in the chat, and people that want to know how to get in touch with you. So we'll make sure that's in the post-event communication as well. And I hope everyone has a good evening.
That's great.
Stay well, everyone. Thank you.